We might as well get started. Good afternoon, everybody. Welcome to this third commission meeting of 2022, the Maryland Commission to Study Mental and Behavioral Health. I want to start with just providing a brief little update on some legislative wins in the mental and behavioral health space here in Maryland. First, and we had talked about this, and it was a recommendation of this commission to join the Interstate Counseling Compact. It was officially enacted. 10 states have signed up for it. We're in pretty good shape at this point. And a couple of other states, or several other states, are still considering it. We're hoping they'll get it through in their legislative session. Unfortunately, Virginia didn't take it up their session. It ended. I know Delaware is looking into it. West Virginia is one of the 10 states. So we have to work on Virginia, Pennsylvania, and hopefully Delaware will come through before their session ends. But, you know, as I mentioned, it was a recommendation here. And what the compact, once their regulations are established, will allow professional licensed counselors and therapists it basically gives reciprocity that they don't have to go through the new permitting or licensing process to be able to see patients in participating states. And so we were one of the first states to participate. We were actually, I think, second to Georgia, coming on board with legislation. And so we're very proud that we were able to step up and do this. We're hoping it'll address, you know, some of our issues in terms of workforce. It does also open the door for telehealth services because that person that may be licensed in another state will be able to, I should say, work with a patient that's here in Maryland. So that can help with some of the telehealth services that we had in place during the state of emergency, but since we're not in the state of emergency, that type of service went away. So that's going to be helpful as well. Also, during the legislative session, we were able to get through the statewide Targeted Overdose Prevention Act, or STOP Act. And the bill did pass the General Assembly. It was signed, and it basically provides greater flexibility in use of naloxone, and encouraging particularly getting naloxone to people early in high-risk groups, those coming out of our criminal justice system, those who recently were in treatment for overdose, non-fatal overdose in the emergency rooms, as well as people coming out of treatment facilities, the homeless service providers, others who can make it available to individuals who data has shown they are at a higher risk of overdose. And then lastly, with regard to funding and the 2023 budget, we were able to put an additional $293 million for substance disorder services, more than $230 million for mental health, and for individuals that are without insurance. There's more than $11 million to support the 6th year of work of the Opioid Operational Command Center, which was, of course, created as a direct response to the opioid crisis. And you know, we're working to make sure that we reduce the dependency and, of course, overdose fatalities in the state, which unfortunately, with the pandemic, you know, kind of took us off course in terms of seeing some successes in reducing overdoses, but the pandemic has had a negative effect on those efforts. So now I'm going to transition to our formal agenda. And as we usually do in these programs, I'm going to ask the commission members to just briefly state their name and their organization or position, and we'll go around and I can start the way my screen is organized. I'll start with Senator Eckert.
Thank you very much, and good afternoon, everybody. Senator Eckert from the Middle Eastern Shore, all of Talbot, Dorchester, half of Caroline, and probably a little more in that third of Wicomico with the redistricting. And we're pleased to be here. And we got the suicide fatality review bill passed this year as well.
Yes.
Thank you, everybody, for your help in that arena.
Thank you. Pat Matuszewski.
Sorry about that.
That's all right.
Hi there. Pat Matuszewski. I'm a family advocate and registered nurse. And again, I really appreciate being a part of this very important work.
Tiffany Rescrod.
Good afternoon, Tiffany Rexroad, the Maryland Department of Human Services, serving in the capacity as our Executive Director for Local Operations.
I see Robin Ricard.
Afternoon, everybody. Robin Ricard, Executive Director of the Opioid Operational Command Center.
Christian Mealy.
Good afternoon, Lieutenant Governor, members of the Commission. Christian Mealy, Deputy Secretary of the Maryland Department of Disabilities.
Barbara Allen.
Good sunny afternoon to everybody. I am the Executive Director of James Place, a nonprofit here in Howard County, and I'm the Chair of the Howard County Opioid Crisis Community Council.
Thank you, and you're right, a good sunny afternoon. Dr. Lisa Burgess, and welcome, Dr. Burgess.
Thank you, Lieutenant Governor. Good afternoon, everyone. My name is Lisa Burgess. I serve as the Acting Deputy Secretary of the Behavioral Health Administration. It's great to be here.
And Dr. Tripahani.
Good afternoon, Lieutenant Governor and the Commission members. I'm an Associate Medical Director at Kaiser Permanente Mid-Atlantic States. Glad to be here.
Glad you're here. Trish Roddy.
Hi, good afternoon. Trisha Roddy, Deputy Medicaid Director.
David Cooney, I guess you're here for Maryland Insurance Administration.
Yes, David Cooney, Associate Commissioner for Life and Health, and I'm standing in for Commissioner Brain today.
Okay, thank you. Kimberly Watts.
Good afternoon, I'm Kimber Watts. I'm a community member, and I'm also happen to be a public defender.
Richard Abbott.
Good afternoon, everybody. I'm Richard Abbott, Director of Juvenile and Family Services, and I represent the Maryland Judiciary on the Commission.
Let's see. Ms. Campbell. Department of Education, Ms. Campbell.
Oh, I'm sorry. It's
That's all right.
It's Gable. And
Gable, I'm sorry. I put an M in there. It is Gable.
That's okay. It's Mary. So I wasn't thinking of me. Good afternoon.
That's all right.
Lieutenant Governor, I'm with the Maryland State Department of Education. Thanks. Sorry.
All right. Delegate Young.
Good afternoon, everyone. This is Delegate Karen Lewis Young, and I represent Frederick County in the House of Delegates. And let me think, what else can I say? It was a good session for health in general, and in particular for mental health and addiction issues.
Secretary Schrader.
Hi, Lieutenant Governor. Thanks for having me back. It's been a long couple years, so I wanted to re-engage and thank Dr. Leah Jones, who has moved on to Anne Arundel Medical Center, Luminous, in a behavioral health role there. But I also want to thank Dr. Lisa Burgess for stepping up, and for Trisha Roddy for carrying the water as we go here. So, but glad to be back.
Okay. Serena Eckwood.
Good afternoon. Hi, I'm Serena Eckwood with NAMI Prince George's County. I'm the board president over there. I'm also a family advocate, of course. So good afternoon, everyone.
Good afternoon. And I thought I saw Carrie Cho. Is Carrie here? Maybe I missed her. Okay. Colonel Butler.
Good afternoon, everyone. Lieutenant Colonel Roland Butler, Chief of the Field Operations Bureau for the Maryland State Police, representing Colonel Jones.
Is Linda Beneski here? Oh, there's Carrie. Carrie Cho.
Hi, sorry about that. I completely lost contact. Anyway, I'm Carrie Guthrie Cho, and I'm the president and CEO of Cornerstone Montgomery, a behavioral health nonprofit in Montgomery County. Happy to be here. Thank you.
Thank you. And I was checking to see if Linda Beneski is here. You can see her on the screen. Okay, I guess not. All right. Okay. And then with the normally we would approve the minutes from March 8th, but I don't know if we haven't sent them out as yet. They are the system we're using is very detailed if you've looked at those minutes, and I'm still reviewing now. It's like 30 pages. I feel like I'm back in law school or something. So we'll get them out before the next meeting, and we'll approve them or approve them electronically. So we'll go to the subcommittee reports. We'll start with the Crisis Systems Advisory Workgroup.
Thank you, Lieutenant Governor. I'll start with system developments. Through a SAMHSA grant, BJ has allocated funding to 5 jurisdictions to expand the availability of peer recovery specialists to support individuals experiencing a crisis who are utilizing a walk-in crisis stabilization center. Those 5 jurisdictions are Frederick, Hartford, Howard, St. Mary's, and Worcester. Funding has also been awarded to Calvert County for the expansion of their walk-in crisis stabilization center. Financial stability and sustainability. The Behavioral Health Administration continues to work closely with the Medicaid Administration and stakeholders to develop the funding structure for mobile crisis response teams and walk-in crisis stabilization centers. Based on the Center for Medicare and Medicaid Services guidelines, regulations and billing codes are being developed. Draft regulations for COMAR 1063 for crisis services are currently being drafted. BHA continues to collaborate with stakeholders, including but not limited to the Maryland Hospital Association. This is towards financial sustainability through emergency room diversion. 988 integration. The governor included $5 million in his fiscal year 23 budget to support the 988 call center workforce. In addition, BHA has awarded 2 grants from SAMHSA to expand the workforce development for crisis call centers. Close to $2 million for 2 years was awarded to support recruitment and retention of the call center workforce. $500,000 was awarded to develop training modules for 988 call centers in Maryland. The training modules are designed to focus on specialized communities. Next, I'll go into the data dashboard and assessment. Maryland has selected the Crisis Assessment Tool, or CAT, as the standardized screening tool to be used with children and adults in crisis. BHA is working closely with the University of Maryland Innovations Institute to lead training on the implementation of the CAT with early adopter jurisdictions, including Calvert, Hartford, and Midshore counties. The CAT will be used by mobile crisis teams and walk-in crisis stabilization centers around the state. I'll move into the report on the young adults, children, and adolescents. BHA, in partnership with the local behavioral health authorities, has launched the Quality Learning Collaborative for mobile response stabilization services across the state. This effort includes statewide technical assistance and quality improvement meetings, as well as county-level readiness assessment meetings and follow-up technical assistance support. This model uses mobile crisis response teams for initial intervention and provides intensive follow-up specifically designed for children, youth, and families. Standardization. Through the work of both the leadership team of the Crisis Stakeholders Committee and the Best Practices Subcommittee, a Maryland model for a comprehensive crisis system has been developed. This model has incorporated key elements of the SAMHSA Crisis Now model, including someone to call, which is the call centers and hotlines, someone to respond, the mobile crisis teams, and somewhere to go, the crisis stabilization centers. In partnership with the Office of Facilities Management and Development, BHA is working on developing and implementing regional comprehensive crisis centers. These regional crisis centers will serve as a coordinating entity to support the key components of the comprehensive crisis system model. This will also allow regional, local adaptability to meet the specific needs of each community. The Western region has been selected as the first location where a regional crisis hub will be developed. Lastly, BHA is contracting with mobile crisis providers to develop mobile crisis and response teams to service children, families, and adults. BHA continues to host crisis system listening sessions among residents and stakeholders in the community. And with that, Lieutenant Governor, I end my report out except for any questions.
I missed the CAT assessment tool. What does the C stand for again? You're muted.
Crisis assessment.
Okay. I would have figured that out if I thought a little bit.
My pleasure. Thank you.
Youth and families.
Good afternoon. Again, Lieutenant Governor, members of the commission, advocates, and guests. This is Christian Mealy, and this report was prepared along with Tiffany Rexroad, my co-chair for the Youth and Family Subcommittee. Our subcommittee held its last meeting on April 11th, and we facilitated 2 presentations at this meeting. The first such presentation was from Paul Ballard. Mr. Ballard is an assistant attorney general with the Department of Health, and he also serves as counsel for the Health Decisions Policy Group, as well as the Quality of Care to End of Life. And in that capacity, I've worked with him and asked him to make a presentation on advanced healthcare directives. And he provided some really valuable information to the subcommittee with a particular focus on the opportunity that Marylanders have to memorialize their wishes when it comes to making mental health decisions related to their treatment. Generally, an advanced directive can outline mental health services which may be provided to an individual in case of their subsequent incapacity to make healthcare decisions for themselves. So basically the way it kicks in is if you have a temporary incapacity or you have a permanent incapacity, which would be something that would have to be declared by 2 physicians, the advanced directive, your wishes therein would then become effective and binding. The document also gives Marylanders the ability to designate a healthcare agent to make decisions about the mental health services that they're to receive in their subsequent incapacity. And so long as they have capacity, they make decisions for themselves. And if they're incapacitated, obviously that's when their designated healthcare agent sort of steps in and has legal authority. This document also governs for the individual, entering into this advanced directive, their preferred mental health professionals that they'd like to work with, preferred programs and facilities. It also allows individuals to identify preferred medications, give instructions about notifying third parties, as well as authorizing the release of mental health information to those third parties. The subcommittee learned that while anyone can prepare their own form advanced directive for mental health services, you don't need an attorney to do so. It only requires 2 witnesses. It doesn't have to be notarized like a power of attorney would. But for everyone's edification, the Department of Health has prepared a a template form that a person may choose to use. And the department's directive is available online through the Behavioral Health Administration. And after my presentation, I'll be posting a link to this template in the chat box so that anyone interested can take a look at that and share that as well with friends, family, and colleagues. The second presentation at the last subcommittee meeting was from Karen Duffy. And Ms. Duffy is the Chief Program Officer with the Maryland Coalition of Families. And she discussed with us the services her organization provides in connection with its new family support peer support program. Sorry. And the Maryland Coalition of Families, it's a statewide nonprofit that's based in Columbia and Howard County. And they offer family peer support services at no cost to families, caregivers, and/or loved ones of individuals experiencing behavioral health challenges. The mission of the family peer support is to connect with families through shared experience, because the program staff there know firsthand what it's like to care for someone with a behavioral health issue, and they draw on that experience to offer emotional support. They share knowledge, they build skills, and they connect Maryland families with resources and opportunities in their own localized communities. The benefits of this particular program, the Family Peer Support Program, includes fostering a greater sense of collaboration and empowering people to take action towards improving their own situations, including developing a greater willingness to work with a member of a treatment team. Additionally, peer support helps families feel more comfortable and capable to navigate systems, understand terminology, and acquire the skills to feel confident in their journey toward treatment, as well as to help make improvements in the practice of self-care while reducing feelings of isolation and avoiding the practice of internalized blame. The Maryland Coalition for Families focuses predominantly on transitional age populations, but they made it clear that they will work with people of any age. However, they mostly concentrate on working with adults who have loved ones with substance use issues in all corners of the state, and also support families experiencing problem gambling. I wanted to also mention, since youth is obviously a major component of the work of our subcommittee, that Maryland Coalition of Families has a program called Taking Flight, which is the organization's young adult group for people aged 18 to 26. And they work specifically to reduce stigma by providing education around mental health issues. They offer informal peer support and support groups, promote young adult leadership, and they also participate in state committees and legislative events to bring youth voices to the policymaking process. If anyone is in need of help from the coalition, and I'll also put this in the chat box, they can call 410-730-8267. They can email the organization directly at referral@mdcoalition.org, or you can visit the website at mdcoalition.org/referrals to complete their referral form. And in summary, all the services that they offer are completely free and confidential. Families will be paired with an FPSS with similar experience. Services are not time limited, and support will be tailored to the specific needs of the family seeking consultation. And in addition to that, we provided legislative updates, many of which were covered at the beginning of this commission meeting. And our next subcommittee meeting for youth and families has been scheduled for June 13th at 1 p.m. So that is our report, and I'll turn it back over to you, Lieutenant Governor.
Okay, thank you, Christian. And I see that Brandon Engel is on monitoring on behalf of Senator Hester. Is Delegate Kelly, I don't think she's on. I didn't know if she had a representative monitoring on her behalf. Okay, so finance and funding.
Question?
Yes. Oh, I'm sorry. Yeah, any questions?
Thank you very much, Lieutenant Governor. Chris, was in the discussion on the mental health advance directives, was there any discussion about where they're kept, how accessible they are, and any future plans on accessibility?
I don't recall, Senator, that was included in the presentation. Tiffany, feel free to jump in if you remember that. I know what they talked about was in terms of where to keep this. It's good to keep it on file with your, it's advised that you can keep it on file with a primary care physician, so that, let's say you're traveling out of state and something happens, if they can reach out to your PCP, then they can access your advanced care directive and your wishes. Most people choose to keep it in a fireproof safe, along with other estate planning documents like their last will and testament and power of attorney if they have one. But he did talk about the execution of the document, which I think I touched on, which was no notarization is required at this point in time, but it does require two disinterested parties to serve as witnesses. So hopefully that quasi answered your question, but they didn't talk about accessibility as much.
Thank you. Yeah, we just had a lot of discussion before Dr. Jones left about the availability of those, if they could be readily accessible to providers in an emergency, then at least you would have access to information about treatment options immediately, so that there could be early intervention. Just something to consider. I guess my thought was maybe eventually they could be embedded in CRISP in some kind of a way so that even our first responders could access those, or anybody who encounters a psychiatric behavioral crisis, and then get that early intervention quickly before it escalates or deteriorates to the point of having further providers in the mix. Thank you.
Thanks, Senator. I just made a note that we'll have to make sure our subcommittee looks and explores, the idea of maybe embedding their advanced directive electronically in the CRISP system, so it could be readily accessed by family members. I think that's a really great idea, if it's not already being worked on, especially. Yep.
And Senator Eckhart, the other thing we talked about was the growing number of online systems where you could put your advanced directive on I'll say a nationwide thing, and then give people permission to get access to that. So that is something that is a growing service. And there's a unending list, if you will, of you can check off your PCP with their name. There's a whole host of things that can be done on those sites so that emergency techs, whatever EMS, could get access to them. That's just an example. I don't sell them, not taking any money. But I also wanted to add on the advanced directives. In a non-clinical program right now, there's a number of us working with MCF as well as our health department with parents who have adult children who are struggling with substance use issues, mental health issues. We're talking to them about advanced directives for them to talk to their loved ones about. And this is a very interesting experiment. Many parents don't want to do it. There's the discomfort of doing this. And at the same time, what we're finding is that when parents, family members kind of relax on that, the stigma of their loved one having these issues, mental health, substance use co-occurring, goes way down. And just having that conversation, that in itself is a movement forward. Whether it becomes broadly used, I don't know yet, but it's an interesting way that we're dealing with stigma as well as education.
Yeah, it's interesting talking about having that advanced directive and having it available when a person is in crisis. And so what Barbara was talking about, those services that you can designate who can have access, because then you have to always have that question in terms of the privacy aspects. So if they designate you, it's not a privacy issue. So that's just something, I don't know if the person would carry something on their smartphone, but that's their choice. They decided to do that. So, okay. The finance and funding.
Good afternoon, everyone. So as everyone knows, the Finance Committee is co-chaired by Medicaid and MIA. So I will give the Medicaid update and then turn it over to David Cooney for the MIA portion. The Finance Subcommittee met last week, and then our next meeting is scheduled for July 11th from noon to 1. The first item that we discussed with the Finance Committee was we gave them an update on the system of care integration and optimization work group. And just to remind folks, that work group brings together our managed care organizations with the behavioral health community and works on initiatives to help improve the system of care. So obviously one of the main topics that this group is interested in is our behavioral health administrative service organization. We are working on the next request for proposals for the next vendor. And so we gave a presentation to the work group members and allowed them to provide comments. They have until the end of the month to provide comments. We covered this topic over 2 meetings with the work group. One meeting was focused specifically just on care coordination. Both groups wanted to make sure that there were enough requirements in the RFP to hold both entities accountable. So both the MCO as well as the ASO. During those conversations, it became apparent, that there's concerns about the current flow of information that's happening. As everyone knows here, that substance use data can't be shared without specific permissions. And because of the low return rate, data right now isn't being submitted between the MCOs and the ASO. So we're going to be focusing on that topic in terms of data sharing at the next meeting for July 11th. And we'll keep you all posted on those conversations. And then secondly, I know I've mentioned to this group in past meetings about the additional money that's coming to the Medicaid program through the American Rescue Plan reinvestment. Again, Medicaid is able to get a 10% additional federal match on certain home and community-based services. And that additional match went from April 1st, 2021 through March 31st of 2022. There is a catch. The CMS didn't just give us this additional 10% additional match to balance our budget. The requirement is we have to take this additional money coming to us and reinvest it back into the program. So we talked with the group about on the behavioral health side, 75% of the reinvestment dollars went into a provider rate increase that went into effect November 1st of 2021. And that rate increase was a 5.4% increase. And then secondly, we took the remaining 25% of the reinvestment dollars and we submitted a plan to CMS to spend those dollars on implementing a new provider type in the Medicaid program. And specifically that provider type is a certified peer recovery specialist. And I'm happy to report that CMS approved that spending plan just last week. Now that's just one approval. Now we have to get the official documents in place to actually reimburse for the service and we have to implement the program. It will probably take, a good 6 to 8 months to implement, but we've got the first approval to begin those conversations. So that's really exciting. And then lastly, I know Dr. Burgess talked about some of the funding, but we also talked about what specifically we're covering under the Medicaid program. So not only are we going to be covering the certified peer recovery specialists, but of course, the governor funded in our budget mobile crisis. So we will be implementing a new provider type for mobile crisis services. And then lastly, in I think it was the last supplemental budget that passed, that was recently signed during the legislative session, there is money for Medicaid to cover 23-hour crisis beds. There was $35 million in general funds given to the Medicaid program. So that's three big new service expansions that are going to be happening within the Medicaid program over the next year. So with that, I'll turn it over to David, and then of course I'll be here to answer any questions.
Thank you, Tricia. As we've been talking about for last year, the big initiative we were working toward in the private health insurance market was a review of the new required reports from insurance carriers to demonstrate that insurers are not applying non-quantitative treatment limitations, or NQTLs, to behavioral health benefits in a manner that conflicts with mental health parity laws. Those NQTL reports were finally due on March 1st of this year, and we received the reports from most of the carriers by the due date, but there were 3 carriers who missed the deadline. There were also additional data supplements that were due on April 1st, and those were also received by the deadline from most of the carriers. Unfortunately, for both the NQTL analysis reports and the data supplements, there were many errors and oversights in the manner in which the reports were filed, and that necessitated amended filings before we could begin our formal review. So at this point, we have received almost all the amended files, and the in-depth reviews have begun. Altogether, we received reports for 193 different health benefit plans, and each report is required to include detailed analysis and justification for 14 different categories of possible NQTLs. These are very large and complex, comprehensive reports. Because reviewing these reports is a very complex and also new process for everyone involved, staff is still being trained on the precise things to look for. We do, however, have some initial observations from a cursory review of the reports, and what we've seen so far suggests that most of the reports do not even include sufficient information and analysis to be considered complete according to the regulations we adopted and the instructions that we put on our website. So for this reason, the MIA anticipates issuing orders for both late and incomplete reports in the coming months, while at the same time, our staff will continue to go through the detailed review. And unfortunately, as we expected, I mean, despite the really clear language that was in the statute and the specific direction that we provided in our regulations, due to the complexity of the analysis here and the lack of experience by carriers in filing these reports, there's going to need to be a significant amount of follow-up correspondence between our agency and the carriers in order to really get all the information we need to complete the review and ultimately determine whether there are parity violations. And this situation is not unique to Maryland. We've consistently heard from other state and federal regulators the carriers have just been unprepared to provide sufficient analyses for NQTLs to document compliance. And this is even though the Federal Parity Act has expressly required carriers to provide these reports since February of 2021. Now, I should note that this doesn't necessarily mean that the benefits under these policies are not being provided at parity. At a minimum, however, it does mean that it appears that the carriers have failed to adequately demonstrate parity for many of the NQTLs in their initial filings. And this is really disappointing because it is going to delay the entire review process. And this is why we are planning, as I mentioned, to issue those initial orders based on the late and incomplete reports, just to give the carriers additional incentive to get us the information we need as soon as possible. And I can now turn it back over to Lieutenant Governor unless there's questions for either me or Tricia.
I guess the question, David, is, what steps can you take if they can't provide data to show that they're complying with the Parity Act?
Right. So as the law is currently drafted, just failure to demonstrate compliance isn't necessarily a violation. So, I mean, we have the leverage of issuing orders and fining the companies for not providing the sufficient information. And that's the course we're going to go now. But it's really, we were meticulous in being as specific as we could in the regulations and the instructions to give the carriers very clear direction as to what we needed and what is not sufficient. We gave a long list of examples of what's not sufficient analysis, and we still got those items anyway. So, I mean, the follow-up, we're just going to have to be very specific on exactly what information needs to be provided and give a tight deadline for the companies to give it to us. And frankly, if they don't, we can issue additional penalties. But we don't, again, have the ability to just say that they're not compliant just for failure to document compliance based on the existing law.
Okay. Well, and this is really a question for the group. And I think we've had these conversations in the past in terms of, what constitutes parity. And the question that I would have is that if you have an acute condition and you have to go through treatment for a period of time, it's generally not limited in terms of the time versus, with some of the substance use disorder, there's like many of the insurance companies used to require 28 days or 30 days, and then, a gap between if you need to go back, if you're, in recovery, you go back and say, no, you gotta be out for 30 days or some period of that. That doesn't seem to be equal. Whereas if you, on the acute care side, if you have a recurrence of something, there's no limitation of time, as well as just the amount of treatment. It's based on what your doctor had said. Said that you should be in this treatment for a period of time. Best practices. So, are the insurance companies, and I know we talked about this, and we've had testimony from people, particularly on the substance use disorder side, maybe on the mental health, it's not quite as severe, but we've been hearing that the private insurance companies have these types of date certain restrictions. And that's open to anyone, not just David.
Sure. I'll start. First, I'll just mention, we haven't seen the very blatant ones like that. If we do see ones that are that obvious, there's really not going to be any amount of documentation that the companies can provide to show parity. So if we do see those revealed in these reports, those type of ones we can probably act on more quickly and actually say this clearly appears to be a parity violation. You have to give us a corrective action plan. The statute requires us to do that before we issue additional penalties. But so if we do see ones like that in the reports, we can act on those more quickly. So I'll at least mention that.
Barbara, am I off on this? In terms of the insurance, private insurers sometimes setting a date to say, okay, you can go into treatment for a certain period of time, and I know there's some that say you need to try outpatient before you do inpatient. But am I confusing it with something else?
Well, I will say that in my experience and listening to a lot of people, the frustration is when somebody's approved for, let's say, 28 or 38 days or 30 days, and then at 14 days, the insurance company changes its mind and says, no, we're not going to pay anymore. And the family goes back to the drawing board to work on that. In some cases, 28 days is simply not enough. And then we look at other states' programs. I think about Fairfax County, which often cannot provide 60 to 90 days treatment. So to me, it's not a simple issue. It's complex and frustrating.
And again, that gets to, how do you measure parity? I see Dennis Schrader, Secretary Schrader has his hand up on that.
Yeah, no, I'm sorry, Lieutenant Governor. I know Tricia Roddy and our team have done a lot of work on the parity issue. I just wanted, I don't know if she's prepared to add to this conversation, but I did want to mention that we've done quite a bit, and it's a complicated issue. So.
Yeah, and Dennis, we have, I did mention on the Finance Committee the work that the Medicaid program implemented in order to produce the documentation that was required for our managed care organizations. Part of it is when you're dealing with plans is getting that standardized approach to reporting that information. That's it's not necessarily that they're violating parity. They just were all filling it out differently and had different interpretations of how to fill it out. And it is a lot of work, but we worked with a contractor. We bought a tool that requires the MCOs to fill out the information in a standardized way. And we provided, again, a lot of technical assistance for our MCOs to make sure that they were doing it right. So I'm happy to work more closely with MIA, but it does take time. You know, obviously the Medicaid program is a bit different because CMS enforces the parity, and again, it is a bit different. And we have a carve out of behavioral health, so it's even more challenging with respect because you're not just looking at one plan. But again, David, I'm happy to work with you on that.
Thank you, Tricia. And I will mention, we did look at some of your materials that were available on the website when we adopted our template forms and everything. So we are familiar with some of that, but definitely happy to collaborate further on that.
Okay. Well, maybe there's just more, I don't know, maybe I'm just losing it or something and not remembering correctly, but I can remember at least I think I remember some of the testimony that we've had from the public where they talked about difficulties with the private insurance carriers that don't want to carry or don't want to cover for a period of time. And I know at one point, I think Carrie Cho, you had mentioned to someone that, you know, Medicaid is better at it, you know, handling it than the private insurance companies. And so I thought that was based on the fact that the insurance company refused to provide the services.
Yeah, the private insurance companies don't cover a lot of what Medicaid covers. And I mean, that's and then what maybe you're recalling. They don't cover supported employment. They don't cover residential. That's nothing that they've ever covered. They have started covering residential crisis. We have agreements with several of the private insurance carriers that they will pay for residential crisis, but that's the only service they've added on since I've been in the business, beyond clinic. So yeah, I mean, that is part of the parity question that I think has been brought up, that if they're not covering, if private insurance doesn't cover what Medicare covers, then is that a parity issue?
And just, you know, equating it to, you know, somatic care, where you have some condition that requires you to be, you know, hospitalized.
Right.
Or even to go through rehabilitation. You know, sometimes you have something that you're in the hospital for a period of time and you go to a rehab center, you know, to be able to, you know, go back home, to function and be able to go back home. And the private insurance normally covers both. And that can be, you know, that could be 30, 40 days, depending on what the underlying condition was. Okay. All right.
Lieutenant Governor.
Yes.
Pat. I would just like to add, I agree with everything that you're saying. I just am very concerned, and I know I sound like a broken record, but where is the parity between people who have both disorders? You know, all the reimbursement comes from one bucket or the other bucket, and these people get lost in the system. And I just think that's something that we have to look at. And getting back to the 60 or 90 days, there was a time when we were trying to use ASAM criteria to help with that. But then there were a lot of issues about what insurance companies will use ASAM, which ones won't. So I know that didn't work either. But from a clinician's perspective, I just don't understand why you would even think about 30 days, 28 days, 60 days. You know, you're assessing this person who's ill, and you need to be developing a plan of care and be treating that person for the needs that they have, however long that takes. I mean, I don't know how you can upfront just say, oh, this person only gets this person only gets that. So, you know, that's my 2 cents.
Lieutenant Governor, could I also just mention, I just want to go back to Carrie Cho's comment. Just to remind everyone, we Medicaid is not allowed to cover SUD residential services normally. We cover it under a waiver. I thought it would be important to just remind if you're trying to compare that service to commercial, again, it's not even something that we're only allowed to cover it under a waiver. Normally, we wouldn't cover most states. I think most have taken up the waiver now, but just in general, it's not a service that we can cover.
Lieutenant Governor, I can't speak for other insurance companies. Since I work in Kaiser Permanente, I can share that we do cover residential treatment and that we do use the Milliman criteria, which is a national benchmark to determine the medical necessity. And even I know some of our patients have stayed in residential treatment up to 2 to 3 months. Of course, it is based on the medical necessity, on how patient is progressing, and that's considered as a pretty widely used benchmark in the entire United States.
I think for substance use, that is true. The private insurers do cover a residential and rehab for that, but not the residential services that Cornerstone Montgomery provides. It's for mental health.
We do cover for mental health services. I'm not referring to substance abuse. I am referring to
mental health.
Mental health, yes.
Okay, well, that's
yes.
new.
In fact, since I do treat children and adolescents, in fact, one of my teenager was admitted maybe 7-8 months ago for about 5 weeks or so, and then was discharged eventually and was much more stable.
Thank you, Gary. I'd be happy to talk offline about some of the specific benefits that you've noted are not covered under private insurance, but are under the Medicaid program, because to exclude certain services, there need to be a contractual exclusion, and we do see those in advance. And if we see things that look to be parity issues, we do not approve them. So I'd definitely be interested to kind of drill down on some of the specifics that you've seen and see what we can find out.
Okay.
All right. Very good. Okay. Public safety justice system.
Yeah, good afternoon, everyone. My name is Brandon, and I'm here on behalf of Senator Hester to provide a quick update on the Public Safety and Judicial System Subcommittee. Since Sine Die fell the day before our usual subcommittee meeting, we did not meet in April. However, there are some exciting developments now that some of our legislation that we sponsored along with Delegate Carey passed. Specifically, last year we were really proud to establish the Behavioral Health Center of Excellence within the executive branch, but in the year of its implementation, some staffing and funding issues arose that stymied its ability to ramp up and really engage with its mission. So this year we passed SB 781 and HB 1018 to provide the center with additional funding and mission support by partnering them with the University of Maryland School of Social Work. The school has several initiatives that are consistent with the center's goals, which means they then also have the expertise and institutional experience to collaborate and assist the center to accomplish its missions. So they intend to engage in the development of the strategic plan to enhance community safety, to provide technical assistance for local governments in developing stronger behavioral healthcare systems, and to facilitate the adoption of the SIM framework and train the trainer courses across jurisdictions. I believe that contracting authority is up to $500,000 a year. So we anticipate that this will be an extremely productive partnership. Looking forward, we plan to engage more with our idea, or some of the ideas that were presented to us during our February subcommittee meeting. And those include the looking into the Memphis model of crisis intervention. And that next meeting will be at 3 p.m. on June 14th. So I hope to see folks there, but other than that, I will pass it back to the Lieutenant Governor.
Okay, thank you very much with that. We now have a presentation from a special presentation that focuses on the Lower Shore Clinic Assertive Community Treatment Program. And I see Dimiri Cavathas.
Yes, Lieutenant
I
Governor.
pronounce your name properly.
Yeah.
Chief Executive Officer of Lower Shore Clinic to present to us. How do you pronounce your last name?
It's Dimiri Cavathas, but it's totally fine. You did great.
Okay.
Yes,
I think I missed a syllable in there somewhere.
No worries, no worries. I will be sharing a screen now. I've been told I can do that, and I hope everyone can see it. And if I can get a nod from somebody that they can see it, then I'll keep going. Great, thank you. So I am the CEO of the Lower Shore Clinic, and we are providing services to a little over 2,000 people in Wacomico, Somerset, Worcester, and Dorchester counties. We provide an integrated model of primary care and behavioral health. And if you're interested to hear more, you can go to our website, Lower Shore Clinic. I am so excited to talk to you today about assertive community treatment. I've been involved in this movement for 21 years now, and I'm really happy to share with you that Maryland has been a leader in this evidence-based practice. And in fact, in the mid-90s, the University of Maryland's assertive community treatment team, which is still in existence today, was a pioneer in establishing this model of care as an evidence-based practice. So I'm hoping that I can present to you the information about it today and generate questions from you. So I will go through this fairly quickly, but I really hope that you can jot down some questions and further the conversation today. This is an evidence-based practice that is reimbursed by Medicaid under the public behavioral health system. And it's geared to engage people that have not responded to traditional health services. So if you have a person that's not going to a clinic, can't make their appointments, maybe they're chronically homeless living on the street or going in and out of the emergency room, this is a program that's designed to engage those persons. The ACT teams across this country are extensive. It's been around now since the 70s out of Wisconsin. Used to be called the Hospital Without Walls. And since then it has evolved into a, not only in America, but also in other countries around the world, including Canada and Japan and Norway. So there are currently 26 ACT teams in Maryland, and actually I'm pleased to report that the Southern Maryland Community Network in Western Shore, Southern Maryland will be starting a new team shortly in that area, which means the majority of the state of Maryland has coverage now for assertive community treatment. A really great achievement for the state of Maryland. So what is an ACT team? It is a team of professionals that focuses on 100 consumers in a geographic location and area. It includes a prescriber, 2 nurses, 2 vocational counselors, a licensed mental health professional, 2 addictions counselors, a team assistant to do administrative work, a peer specialist, peer counselor, psych rehab counselor, a housing specialist, and a director. And that team works together on a daily basis to serve 100 consumers that are not responding to traditional services. So where are those services provided? They are not site-based. They are based out of where people are. So it could be a person's home, their vehicles, if they're living in their vehicles, on the street, shelters, hospitals. Sometimes people do come to the office, but the vast majority, over 90% of services, are usually provided at the location of where the client is. And this program in particular has a real significant concentration of people with co-occurring issues. And we're not talking just about addiction and mental health issues. We're also talking about other kinds of chronic health conditions that impact people's health. High blood pressure, diabetes, metabolic syndrome. These are all kinds of chronic health conditions, which makes the ability of an ACT team to have, let's say, nursing engage people even more important. So what happens with this team? They are usually in cars. There's not an RV. I know a lot of mobile programs have RVs. This is actually usually about 12 cars. We have 2 teams that serve 200 clients in the region we're in, and every staff person has their own car. And those people go to where the person is at any time, day or night in the week. Person-centered plans are developed with the person really focused on what they want to accomplish. The whole team meets with the person, so this is not a siloed program. It is a program where a group of people know a group of people. Support is available 24/7. Every day, the teams get together and review every client so that people do not get lost. people do not get lost in the shuffle of what happens on a daily basis. And there is really no arbitrary time limit for services, which makes this somewhat unique. And the staff to client ratio is 1 to 10, which is, again, a very low client to staff ratio. There is a substantial percentage of people in assertive community treatment that have Medicare. So usually an ACT team will considerably have around 40% of their clientele with Medicare, dual eligible clients or people with Medicare only. And a part of that is because of the chronic health conditions, but also part of it is that there is a gap in access to care for people with Medicare. To Maryland's credit, they have this Medicare ability to serve clients in the assertive community treatment team, which is really a standout opportunity that the state of Maryland provides to our citizens. So what are these activities? What do they do? You can think of anything and everything. If you think about the fact that 80% of a person's health is determined by the social determinants of health, not healthcare, not a medical intervention, not medication, but in fact, engagement in housing, employment, nutrition, and all the other things that impact people's health. The ACT team is specifically geared to address these issues. And we're talking from grocery shopping, healthy eating, to finding safe and affordable housing, benefits, helping people find a place to live, creating social relationships, reconnecting to spiritual centers. ACT teams also provide crisis management, which is a great added service in the crisis system that Maryland is developing, such a robust system that Maryland now is putting together. The ACT teams are a real critical piece to this for this very small cohort of people that cost a significant amount of money and a significant amount of medical care in the state system. There's a lot of coordination with social agencies. There are employment specialists on the team, so they even help people get jobs, for example. We do get people with children, and we support their children as well in the ACT activities. We really try to help people manage their money. If you can imagine, you're getting $800 a month, if anything, as a benefit to live in the community. How do you make it with $800 a month? It's extremely difficult. So the ACT teams work very hard to figure this out with the clients and troubleshoot those issues. And also medical care, these significant chronic health conditions. Please keep this in mind because the last slide of this presentation will show you why this is important. That the chronic health conditions around what a person is dealing with is really significant on ACT teams. And the ability to impact people's nutrition, the ability to impact people's medication management, help them with ordering medications, staying on medications, and adherence protocols is one of the critical pieces. I always remind people that it takes 80% of adherence to medication for it to actually work. So no matter what medication you take in any kind of condition, if you don't hit the 80 percentile, you might as well not be taking it. So there's significant focus on medication adherence protocols that the ACT teams do, and which is a really critical piece. So what does this data say about ACT? Why is this an evidence-based practice? Well, there are over 50 published empirical studies. This is one of the most studied services in the behavioral health system. And I want you to know that Maryland really supports this program. They financially support it properly. And I want you to also know that their outcomes are really quite impressive. Decreased hospital use, there's more independent living and housing stability, retention and treatment, and increased satisfaction. It's a little harder to have success stories around employment and substance use because of the conditions that people are dealing with, but all the ACT teams work really hard to make an impact in those areas as well. So what does an ACT team really mean to this commission in particular with the opioid epidemic and addiction issues in particular, right? Well, prescribers on ACT teams can provide medication-assisted treatment. So I have 2 prescribers, 1 psychiatrist, 1 psychiatric nurse practitioner, and they can provide medicated-assisted treatment to clients dealing with substance use issues. This is really a big deal because if you have a prescriber actively engage with somebody, the ability of adherence to MAT is really significantly increased. Our primary care practice is also bidirectionally medicated assisted treatment capable. So having that combination with the nursing, the prescribers, supporting people in MAT is really important. ACT teams follow a harm reduction philosophy. We understand people don't change on a dime, and people change over a course of time, and that change is not linear. It looks like a roller coaster, really. And harm reduction and the understanding of harm reduction in the person's recovery is really critical. We follow a housing first philosophy. We believe that ACT teams believe that people need to be in housing to actually stabilize, and that no matter what is happening with a client, the number one goal if someone's homeless is to get them housing and then scaffold services around them. And finally, ACT teams believe that addiction is a result of trauma. Trauma has created significant conditions in people's lives, and that people are self-medicating to deal with trauma. It's a rare event when someone has a really amazing life and then all of a sudden uses a substance and becomes addicted. If you look at the data, the vast majority of people in addiction is a result of significant trauma in their lives. So ACT teams are really geared to address these issues in particular. And what's great about ACT teams, like Pat had said earlier about co-occurring disorders, that the teams have specific co-occurring disorder specialists on their teams. They have an understanding of the intersection of mental illness and addiction and how it works. And you actually get scored on a fidelity scale for our teams in this manner. So there's a real rationale around this. There's a lot of focus on this with the ACT teams, which really gives it a real leg up on non-traditional services being effective. ACT teams are experts in addiction, not only with the medicated assisted treatment, but the role of the co-occurring disorder specialists within the teams, and the idea of these teams having full responsibility for integrated treatment. So these co-occurring disorder services are absolutely integrated and seamless within the team, and that the client themselves do not see any light between the staff in this integration. And that's a really important aspect of engaging people that are having a lot of issues. So there's also a lot of research around ACT teams addressing criminogenic behaviors. And there's a number of different models that have been looked at to really help people that are, for example, going in and out of jail. As we all know, our jail and prison system has a significant portion of clients with significant mental illness and mental health issues. So ACT teams are aware of this. They are trained in this aspect of dealing with people with some criminal background, a criminal past, and to try to break that cycle in the process of their services. And then finally, ACT teams are training crisis services. We actually get scored on crisis services. The team has a 24-hour responsibility to deal with these crises for those clients. They're available whenever the client needs it. We have persons on call. We deal with schedules to deal with the needs of clients based on what's going on in their lives. And that actual crisis plans are developed for every client on the ACT team. So there's a real significant discipline in understanding and expertise in the responsibility of crisis services with these clients. So I want to give everyone really good news. These ACT teams are sustainable. So once you get a team up to around 70, 80 clients under the public behavioral health system of Maryland, it is future sustainable. So all you need to do is provide upfront money to start a team, but then once a team reaches a certain percentage of their members, based on the structure of what organization they're in, basically, it is sustainable. So one-time money is usually a very popular thing to say to funders. So one-time money is here. This is a one-time money approach, and it's really something that's one of the strengths of the program in Maryland. And then here's the final slide to you that I want you to see, that not my data, but the data of the state shows that the work we're doing is actually reducing the cost pre-post. So what you're seeing is a group of our clients 12 months prior to admission to the program, and then 12 months after the admission to the program. And I'm sure Tricia Riley is going to put a lot of holes in this, but Tricia, give me a break on this one, okay? I wanted you to show there's a trend. There's a trend here on the lowering of cost over time. So I hope that this has intrigued your thoughts around this service, and I'm going to stop and stop sharing and take any questions you'd like.
I'll ask the first question then. You mentioned that it's really a setup for those individuals who have not been successful in, I'll call it traditional treatment or other treatment methods. How do you find your clients? If they're, like you said, if they're on the street, how do you, do you go up to a person who's on the street who, is showing signs of mental instability? How do you find it?
It's a great question. What the health system will tell you, Lieutenant Governor, is that they know who those persons are because they're in and out of the ER. They are on the street a lot of times. So homeless outreach teams know this as well. And one of the great strengths of the Maryland system is it allows us to engage people initially and be reimbursed for that. So you might have a person living on the street with a significant and persistent mental illness, but we are allowed to actually go out and engage them upon referral. And another strength of Maryland's system is that the barrier to referral is extremely low. So even a self-referral is allowed. So there's a lot of different ways that this occurs. A lot of times the ERs and the inpatient units will contact us. We'll have homeless outreach teams contact us, jails contact us, as well as the public behavioral health or service agencies and health systems, which will see a person running up significant health costs, real significant runs in cost and inpatient care in particular. And we'll get a call for that as well.
Okay, yeah, I guess it does make sense that emergency rooms, as well as the local jails, might be, good referrals where they know that they have a person there who did something that violated the law, but has severe mental illness or those types of services.
Yes, usually the persons that we're getting are in that 5% of the population of Medicaid that costs 50% of the budget, or the 1% of the Medicaid population that costs 25% of the budget. So they're usually on the radar. And these ACT teams are specifically designed to engage and deal with these kind of issues.
So I have some questions or comments.
Yeah.
First of all, comment, when I look, Dimiri, at various things, one of the things we talk about in recovery is recovery capital. And that's the set of tools that someone has. A simple example is housing. If you don't have a place to stay, you're couch surfing, you're in a tent, you're in your car, that's not a stable environment. Co-occurring, whatever. So there's a lot of things in here like grocery shopping, assistance, helping people do things that many of us just take for granted. Even as simple as purchasing and taking care of clothing, which I really, really like. And I appreciate so much the help with identifying job skills. And we do have some jurisdictions which have programs through Department of Labor, which are very helpful. The coordination, generally an individual in these cases often doesn't understand that coordination between services. So that's a lot of great or good stuff. If I could buy an act, I would love to buy it for many jurisdictions. So my only question I have for you, Dimiri, help me understand because I think I missed it. When you talked about ACT teams are sustainable, you said once a team reaches 70 to 80 members, it's sustainable. I missed who those 70 to 80 people are or groups are.
Thank you. Yeah, so when a team builds up a census of consumers of around 70 to 80 clients, and again, it depends on the organization that's running the team, it is officially break even at that point. So when I say sustainable, in other words, it's not losing money anymore, and it will be sustainable for the future. So a team of 100 clients with an ACT team, a fully staffed team, is sustainable for as long as Medicaid exists. How's that? And the organization can do a good job.
Is that because the funding and the reimbursements for those services? Okay.
Yes, correct. So the Medicaid rate is established. It's a good rate actually in Maryland. I want to give credit to Maryland to having a rate that supports an ACT team properly, and that that program will be sustainable. So you really only need startup money. So usually an ACT team needs, in this day and age with inflation, around $500,000 to $600,000 to get going. And once you do it and it gets to a certain size, then it moves on. I also want to thank you to talk about the peer approach as well. And I heard earlier about Medicaid getting the approval for the peer specialists. ACT teams have had peer specialists in their teams for decades. And in particular, our peer recovery specialists focus on wellness recovery action plans with each client to talk about this capital that you described, Barbara. I really appreciate you bringing it up in particular.
Important.
Yeah.
Thank you.
Any more questions for Dimiri?
I have a question for Dimiri. Thank you, Dimiri. It was a great presentation. Could you tell us how long typically a client stays within your system?
It's a great question. We actually have to track that for our evidence-based fidelity. And the average stay is around 3 years.
Senator Rucker?
Thank you very much. Dimiri, good work. It's good to hear such positive results. But I did have one question. Have you done any kind of data analysis or financial analysis of how much you've saved in either emergency room visits or other episodes of decompensation having to go back into the hospital? Do you have any sense on that?
Yeah, I'm very nervous to say it in front of Trisha Roddy. But, you know.
Sorry about that.
No, it's okay. I mean.
I'll plug my ears.
Well, we have, you know, and it's close to $1 million from pre-post. Now, what I can say to you is we're really looking into what this is, why this is, and honestly to validate it. And I'm very excited to tell you that we have obtained funding to hire a full-time research assistant professor from the University of Maryland School of Social Work to be here for the next 3 years to study what we're doing. So I'd like to just use the CRISP data because it looks really good and say, you know, yeah, we are. I think I can confidently say we're definitely saving money. I'm not as confident to say how much, even though the CRISP data says that. And it does break down where the money is saved. A lot of that is surgical, for example. But I want to come back at some point to this fine group in a couple of years and give actual research that proves what we're doing. So
thank you.
Thank you.
Now, my other question, and I just lost it out of my head, but I was going to say, what's your turnover in your staff? Have you been able to me, it's the relationships and it's the stability of the relationships over time. So have you been able to kind of capture what constitutes keeping a team together?
Yes, but it's very difficult at the same time. So we actually do have to measure turnover as part of our fidelity review. We get reviewed by the state of Maryland. So it's usually 1 or every 2 years. So we actually have to track this. And we're in the 30 percentile range, which is not ideal. The ideal is around 15%. So we're really double the ideal rate. And part of it had to do with the fact that this is a very non-traditional program, and most of our schools, and listen, I went to the School of Social Work. I love my school. I actually was an adjunct there for 11 years. But we don't really prep people for this kind of work. And it's really geared more for clinics and other traditional services. So you get someone to take the job, they're in this very non-traditional approach, and it's sometimes just not a good match. And that's what happens. Yeah.
It's helpful so we know what we need to do going forward.
Yes.
If it is something we want to capture and preserve and then prepare people to be able to handle it. Yeah. Thank you.
Absolutely. Yeah.
Thank you, Lieutenant Governor.
Yeah. Thank you.
Pat, were you about to ask something?
Yes. Thank you. Dimiri, great presentation, I have to say. And thank you for being here. But when you were talking about the reimbursement, meeting the fidelity measures does result in the reimbursement. Is that correct?
Correct. So this is one part I don't like, and I didn't plant this question either, Lieutenant Governor. There is a connection of the fidelity rate to a higher rate. And this creates a significant amount of stress on the organizations around this.
I'm not familiar with fidelity rate. Can you define that for me?
So there's a standard mobile team rate in the public behavioral health system. And then if you meet a score in this fidelity it's a research fidelity scale, then you get a higher rate as a result of that. So these 26 teams that'll soon be 27 teams are constantly being reviewed every year to every 2 years. And we're all we're holding on to make sure that we pass to a certain level to get the higher rate. And it does create quite a dynamic, and it creates a dynamic that can be very tense at times. And that is the one thing I wish we could change. But I don't expect the commission to do that. I know you have a lot of other things going on, but that is something that is very difficult.
But the data does assure us of the quality. So the higher they meet the fidelity measure, the more quality the whole system gets, the patient, everybody. So that would be good data to see, to see where the team, is actually sits most of the time. And then that also tells us, because, we talk about insurances now and, what do you get for your money? Those kind of things and, outcome measures and all of this. But doing this ACT team, I just think it's so organized and it really gives you a picture. Plus, as you said, and everybody knows I feel this way, it really does give you that integration between these two disorders, which we know that the majority of people have. Correct?
Yeah, it's so important. Our clinic is licensed as an integrated clinic, and obviously the ACT teams are also a very integrated model. And it really is critical to be able to merge all these disciplines, in particular around addiction and behavioral health, and the somatic care too, is so important. It's so important.
Yes, thank you.
Thank you.
Last, maybe it's a statement. It has to do with the saving, Dimiri. One of the areas, of course, if you're reducing the amount of people going into the hospital or even just going into the emergency room, there's a savings in terms of the expense, but also just the opportunity, since opportunity cost, where one less person that's sitting in that emergency room tying up resources that could go to someone else. So I know it gets to be tricky to determine what actual savings, but if it's one of the areas that I think what we've heard a lot about, particularly from the hospitals, is if you have a diversion away from going into the emergency rooms, there's a savings there.
Yes, thank you. Not only did the ER visits go down, but the real savings occurs in inpatient days. That's where, and when you look at the CRISP data in particular around that, you'll see a big shift in inpatient costs versus the ER cost. Yeah. And Tricia, thank you for being nice to me.
You're welcome.
When I saw you, I was like, oh my God, she's going to just destroy my CRISP data.
No, the one comment I will make, it's just in general, CMS is pushing us to be to have payment based on outcomes. We are aligning even and changing the way that we're paying primary care. It's not mandatory, but it's an option. But CMMI is pushing us to build the payment around both capitation as well as outcomes and performance based. So it's just, that's the movement and where the federal government wants to see us go.
Actually, thank you for that, because we are part of the Maryland Primary Care Program, and it has been a godsend to us. We think it's a wonderful program. It really helped us through the pandemic in particular. And, Dr. Haft and all that group over there have been just wonderful. And I want to specifically thank you for that as well. It's been great.
Absolutely.
Okay. Dennis, Secretary Schrader.
Yeah, thank you, Lieutenant Governor. I had a question. As you were briefing, which I found fascinating, and by the way, I live in fear of Trish Roddy too, so don't feel bad. I would ask, do you see an integration of this or a coordination? We have put a major emphasis on building crisis centers over the next 10 years. Matter of fact, the governor just got the first $1 million into this last budget. We're going to start a process in Western Maryland. We've identified 4 regions. That doesn't mean there might not be more. But how do you see the coordination of what you're doing with ACT with the crisis center game plan?
Thank you so much. And that is a great question. I worked one night a week for 8 years on a mobile crisis team in Howard County out of the grassroots building. So I'm very familiar with how mobile crisis teams work. And I see a real beautiful integration and marriage between the centers for crisis, mobile crisis teams, assertive community treatment teams, and residential crisis beds. And I see those 4 programs really, dancing together to serve clients in a real seamless fashion. And they complement each other so well. You have the mobile crisis team doing the real short-term intervention, the immediate short-term intervention, maybe the crisis center following up with that, then maybe putting a client into a crisis bed with an assertive community treatment team coming along to further the treatment afterwards. And I think there's such a huge opportunity for that.
Do you think there's a possibility we can reduce the number of forensics beds through diversion with this, with the combination of this program and crisis? Because that's the other thing we're looking at. And again, we're peering through a crystal ball that's 10 years to 20 years from now. But what do you think could this lead to a reduction in the number of people who are put in jail because the law enforcement or judiciary community gets them first?
I mean, I do think I know I had experience in Montgomery County with pretrial services as an example. So I think that there's a web of things that we can do to prevent people from entering the criminal system. I do think when you beef up the crisis system, it will prevent future, criminal interventions that would occur with our clients. The forensic bed issue is very complicated because of the courts and the way they operate. Mental health courts can be very helpful too at times. So I do think, though, that you could definitely prevent people from entering the system itself. I think there's definitely opportunity there.
Thank you. Appreciate it. I'll be following up with our staff offline on this. Very interesting. Thank you for the presentation.
That's wonderful. Thank you so much. I really appreciate that.
Dimiri, thank you very much. It was very informative.
Thank you so much. Thanks for having me.
No, thank you. Well, thank you. Thank you for what you're doing, and thank you for taking the time to talk to us. It's an excellent model and appears to be showing results. We'll talk to Trish separately about that. Verify.
Thank you.
Just joking. Okay. All right. At this point, we can move on to public comment, unless there's anything that any of the commission members want to raise before we go to the public comments. Okay. Hearing none. We'll go to that portion. And those in the public who have signed up to speak, as well as just the public who's listening in, just want to note that for every meeting, written testimony that's provided ahead of the meetings, as well as through tomorrow, will be posted online for the public's review and consideration. So we have a number of people who signed up to speak, and I'll start with Chris Floor. Yes, I think I pronounced it right. Chris Floor, Flohr. Okay, Katie Rouse. Did I unmute myself?
Yes, good afternoon, Lieutenant Governor and Commission members. Thank you so much. Thank you so much for the opportunity to join you all today and to speak. I'm Katie Rouse, representing Honor of Maryland, and for 30 years, we've brought the consumer and peer voice into matters of behavioral health system planning, policy, and improvement efforts. And like some other organizations providing testimony today, we wanted to take this opportunity to share some very serious concerns regarding the proposed transfer of the Spring Grove Hospital Center campus from the Department of Health to UMBC. So I do want to say very clearly that we do not begrudge UMBC any opportunity to build on its success. They are really a shining star in the University of Maryland system, and I would say that even if I weren't a proud alumna. But our concern about this proposed transfer is a lack of clarity, consistency, and stakeholder input regarding the plans for Spring Grove, because it's not only going to impact the nearly 400 people who reside in beds there, but it's also very demonstrative about the state's commitment to sustaining accessible and equitable and responsive public behavioral health services. So in that facilities master plan, Spring Grove was rated the worst in infrastructure out of all of the inpatient facilities, but the planning process for transitioning services and residents was pushed forward a full decade into phase 3, which was to start in 2032. And that process of organizing those transfers is anticipated to be challenging because so many of the people who are there have complex medical, legal, and behavioral health considerations. And there are many folks who are subject to court order in terms of their future. So please know we are very, very much in favor of the state moving people out of hospitals, especially out of places with significant historical stigma and inadequate amenities like those at Spring Grove. But this proposed transfer to UMBC seems to make the process vulnerable to acceleration or pressure by interests that are totally outside of the behavioral health system, since UMBC is slated to get full use of the campus as soon as all of the buildings are vacated. So if this campus is already so difficult and expensive to manage, then what is gained by adding another layer of bureaucracy by having another partner outside the Department of Health? And if the state's goal is to more quickly move people out of Spring Grove's aging buildings and into better care, then why was the planning process deferred for a decade and what has changed now? How is the system preparing community providers to serve folks who do have more complex medical or legal needs by expanding programs that can help people, like the ACT teams that Dimiri just spoke about, or programs that work with folks who are currently institutionalized and to receive better care in the community, like Baltimore City's Outpatient Civil Commitment Pilot Program? I just want to say that the future of Spring Grove Hospital is not just a business decision. It's really tremendously symbolic to the people who received care or something less than care at that institution, to people who visited loved ones there or saw their loved ones remain there for several years, or even sometimes until their deaths because there was a lack of appropriate step-down services in the community. So to move forward with such a major decision about this long-standing institution without a meaningful process to inform or engage or partner with peers, families, advocates, and providers, that's just not something that a trauma-informed and recovery-oriented and person-centered system would do. And so we want to use this time to just respectfully ask the Commission to please hold our system to a higher standard and to thank you for hearing us.
Thank you. Okay, Lori Doyle.
Thank you, Lieutenant Governor and members of the commission. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. We have 105 organizational members who provide community-based mental health and substance use disorder treatment and support services. We, as Ms. Rouse are very concerned about the last minute appearance of this transfer on the Board of Public Works agenda. This seemingly precipitous action involved little to no input from stakeholders and drastically speeds up the process by 10 years of the timeline in the master facilities plan for addressing Spring Grove. We have a statute on our books. It's been on there for quite some time, for decades now, called the Community Services Trust Fund. And it was passed by the General Assembly specifically for circumstances like this: the sale, lease, transfer of a facility. And the creation of this fund was to allow the money to follow people into the community so there would be adequate services for them when they leave a state hospital. This transfer will basically preclude that Community Services Trust Fund from getting a dime. You know, the land housing Spring Grove is very valuable property. And we know that because this has been a subject of conversation for many, many years. I've been around a long time. Not only UMBC, but many developers have wanted to buy this land, and we're willing to spend a lot of money on it. So what do we do now? We have providers who are out here who have been serving people, taking folks out of places like Spring Grove, but we're faced now with housing challenges, with workforce challenges that are unprecedented. We need an infusion into the community, and we need to be more creative in how we provide our services. You just heard the ACT teams. There's a lot of innovation happening in the community. We need the opportunity to sit down with you all as partners and talk about the various options and alternatives before we move forward with a plan like this. So we ask that you postpone this decision, bring stakeholders together in a thoughtful and meaningful, planful process to really try to make decisions on what's best for the folks at Spring Grove. After all, they are in the state's care, and we should be doing the best we can by them. Thank you.
Thank you very much. Dan Martin.
Mr. Lieutenant Governor, thank you very much. Commission members, it's a pleasure to be here. I'm going to echo a lot of what my colleagues, Ms. Doyle, Ms. Rouse said. They probably said it much more eloquently than I will, but I'm here to talk today on behalf of the Mental Health Association of Maryland, again, about the proposed transfer of Spring Grove Hospital Center to UMBC. And I know this commission, it's kind of, you know, outside of this commission's purview, but because the Board of Public Works will be making the decision, but, you know, since this is the Behavioral Health Commission, felt really compelled to, you know, bring it to your attention. So, you know, I just want to say up front that we are not here to derail this in any way. Like Ms. Rouse said, you know, we think UMBC is a great institution, and this may be a very good thing for our state, but we do have some concerns, you know, namely, we don't know what we don't know. The remarks on the BPW agenda item for this transfer indicate that this action aligns with the Department of Health Facilities Master Plan that this commission was briefed on a couple of months ago, and we were briefed on it too, and appreciate that briefing. And according to the plan, as you heard, the plan for the transition of services at Spring Grove is part of phase 3, which is slated to take place in 2032 for 10 years, starting in 2032. Beyond that, recommendations in the plan related to Spring Grove are slim at best, and there is no mention of transferring Spring Grove campus to UMBC. And our concern here is just, you know, same as my colleagues have indicated, that there's not been an open process or discussion about the plans for Spring Grove. The first time we even heard about the master plan was last fall when it was released. And, you know, we were not notified of or included in any planning process, you know, leading up to that release. And, you know, listen, we agree with the Department of Health that the Spring Grove facility is substandard and is sorely in need of attention. And we are eager to hear about the department's plans to improve care and the environment for patients and staff there, both in the future and in the short term. But these plans are not discussed in the facilities master plan, and they should be shared for public consideration and input prior to the proposed facility transfer. And that's, what's happened when other institutions have closed, as Ms. Doyle alluded to, when both the Eastern Shore Hospital Center and the Crownsville Hospital Center were closed. There were comprehensive public processes that resulted in a modern new facility on the Eastern Shore and investment in community services surrounding the Crownsville facility. And that's all we're saying here. This is a big decision that warrants more conversation and engagement with the community prior to the transferring of the property. And that's what we'll be asking for tomorrow at the Board of Public Works. And so, again, I know this isn't directly in your purview, but you're the Behavioral Health Commission. So, felt compelled to share these thoughts with you, and thanks for the opportunity.
Thank you, Dan. Evelyn, are you going to talk about this matter in particular?
No, I agree with all the previous speakers, but I was really planning on speaking on something else.
Okay, can I ask you to hold for a moment? I'm going to ask Secretary Schrader if he wants to respond to any of the concerns that were raised.
Yeah, thanks, Lieutenant Governor. And I'm glad for the feedback and the input. And I want to say several things that may help clarify people's concerns. One is Spring Grove is going to remain open, and the Department of Health is going to deliver hospital services to our patients, and they'll be unaffected for the foreseeable future. It takes about 5 to 10 years to develop a plan that's this comprehensive. And so the master plan lays out the framework. We are now going to move into what would be considered program development planning, where we would bring a lot more people into this, which would include things like crisis services that I mentioned earlier. So the primary purpose of the transfer to UMBC is to allow both UMBC and ourselves to get into a long-term planning process because UMBC has expressed interest in this property for quite a while, and they're an outstanding institution of national distinction. What we will do is organize a process to begin talking about the very things that have been brought up on this call. So we agree with that. We did mention in the master plan that Spring Grove is one of the action around Spring Grove is one of the things that was brought up in the master plan, which the master plan itself took 5 years to develop. When I was first here in 2017, there was very little money in the capital budget for the health department. And the first thing we need to do is to have a master plan and begin to put money in. And DBM has worked with us on that, as well as DGS. And the $1 million that we got for starting the crisis center development was specifically enabled by the master plan. And so we're going to continue to maintain and use these facilities for the duration of the operation. The lease back is 10 years to start with another 5-year if we don't get everything done that we need to. There are 2 5-year renewal options. So this is a 20-year process, and we have had some preliminary conversation with the community about what they would like. They're very concerned about the traffic in the area. They want Wade Street closed, and we've been working with them on that. As far as the evaluation process, there was a review of the value of that property and the estimated demolition, remediation, and other historical preservation exceed the value of the property, which is why it's determined to be $1. So there will be a very robust process as described. This is just the beginning of a decade-long conversation. So I'll stop there, Lieutenant Governor. Thanks for the opportunity to say a couple of words.
Thank you. And I saw there was a question at the about the Board of Public Works. It takes place in Annapolis and starts at 10 o'clock tomorrow morning. It is also live streamed on the Board of Public Works website. And so if you use your browser and just type in Board of Public Works, you'll find it. Okay. With that, Ellen Burton.
Thank you. The only thing I was going to briefly say about the hospital transfer is that, to me, it seems that it's important to decide where these patients would go and if a new hospital is going to replace it and where, so that if a new hospital is going to be built and that area is determined to be the appropriate place, then maybe some of the land could be retained for that purpose. But mainly, I wanted to thank the Commission and the Lieutenant Governor for listening to the testimony of the many families that have come before you to talk about the tragedies caused by the current danger standard for emergency evaluation and involuntary hospitalization. This standard has led to homelessness, incarceration, suicide, and violence. The many families that bravely testified before this commission about their families caused by the danger standard made it clear that our standard needs to be defined because it is not interpreted as it's interpreted as often requiring imminent danger, is not interpreted to include grave disability or a psychiatric deterioration that would prevent these tragedies before they occur. Many of these families talking about these tragedies had an extremely difficult and even traumatic time talking about them. They are asking me, why did we bother going through this? The Commission has not even discussed the report by the Health Department to modify the standard and has made no recommendation of their own. The Commission was the one who heard all the testimony from them. The stakeholder group, the department, did not hear any of public testimony. So my question is, when is the Commission going to discuss the report publicly and make their own recommendations? In the January meeting of the Commission, Lieutenant Governor, you mentioned that the Commission could do this. So my question is, when can it be scheduled? Thank you very much.
Thank you. I think we can look at scheduling that soon. Probably will be a recommendation. We have one more report that we'll have to make, and I would expect that after we have some discussions about it, we'll put something in that report.
Thank you very much.
Okay. Thank you all, everyone. Our next meeting will be July 12th. And at this time, it will also be virtual. If it hasn't been presented before, the email contact for those who want to submit testimony is mbh.commission@maryland.gov, and Maryland is spelled all the way out. mbh.commission@maryland.gov. All right. Well, thank you, everyone. And thanks for those who testified. Dimiri, thank you very much. That was very informative. Thank you to those from the public members who spoke today. Katie Rouse, Lori Doyle, Dan Martin, and Ms. Burton, thank you very much. Take care.